Welcome to a new video. In this session, we'll be covering the anterior abdominal wall in detail. By the end of this video, you'll be able to identify the boundaries and surface landmarks, understand the layers including fascia and muscles, recognize the nerve and blood supply, and relate key clinical correlations, including congenital anomalies and surgical relevance. Let's begin our easy and structured breakdown of this important anatomical region.
The anterior abdominal wall. The anterior abdominal wall is a musculo-aponeurotic structure confined to the anterior and lateral aspects of the abdomen. It is bounded above by the xiphoid process and right and left costal margins. Below the anterior part of the iliac crest, folds of groin, pubic tubercle, pubic crest, and pubic symphysis. And on each side, it is separated from the posterior abdominal wall by the mid-axillary line. Clinically, the term anterior abdominal wall includes both the front and side walls of the abdomen. Surface landmarks. The surface landmarks such as costal margins, umbilicus, anterior superior iliac spine, iliac tubercle, linea semilunaris are important guides in orienting the clinician to the location of the viscera in the abdominal cavity. Bony landmarks, costal margins. The cartilages of 7th, 8th, 9th, and 10th ribs form the costal margins. The 7th costal cartilage is the lowest cartilage to reach the sternum. The right and left costal margins run upward and medially toward the side of the xiphoid process to enclose between them an infrasternal subcostal angle. The costal margin reaches its lowest level in the mid-axillary line. Xiphoid process. It forms the upper limit of the anterior abdominal wall in the anterior median plane. It lies at the apex of the subcostal angle, and its apex is sometimes bent forward and hence easily palpable beneath the skin. The xiphoid process lies at the level of T9 vertebra. Iliac crest. It forms the lower limit of the anterior abdominal wall at the side and can be traced forward to the anterior superior iliac spine. About 5 cm behind the anterior superior iliac spine, a prominent tubercle of iliac crest can be felt on the outer lip of the crest. The highest points of iliac crests lie at the level of L4 vertebra, just below the level of the umbilicus. Pubic symphysis. It forms the lower limit of anterior abdominal wall in the anterior median plane. It is easily palpable and lies at the level of coccyx. Clinical correlation. Congenital anomalies. The most important congenital anomalies of the umbilicus are Exomphalos, Exomphalos, failure of mid-gut loop to return in the abdominal cavity results in exomphalos. Since the intestine protrude through the defect in all the layers of the abdominal wall at the umbilical ring, a thin transparent membrane, the amnion, covers it. Congenital umbilical hernia. In this condition, the intestine protrudes through the umbilicus due to weakness of umbilical scar. Hence, it is covered by the peritoneum. The umbilicus is therefore considered as the hotbed of embryology by clinicians. Superficial fascia. The superficial fascia contains a variable amount of fat, maximum in the lower half of the anterior abdominal wall. The anterior abdominal wall is the major site of fat accumulation, especially in females, leading to obesity. Above the level of line joining the two anterior superior iliac spines, the superficial fascia consists of a single layer, but below this line it consists of two layers. A superficial fatty layer, Camper's fascia, and a deep membranous layer, Scarpa's fascia. The space between the two layers contains superficial epigastric, circumflex iliac, external pudendal vessels, and superficial inguinal lymph nodes. Camper's fascia, superficial fatty layer. This superficial fatty layer of superficial fascia of the abdomen is continuous with the superficial fascia of adjoining areas of the body. It is devoid of fat. It is replaced by an involuntary dartos muscle. Scarpa's fascia. This deep membranous layer of the superficial fascia of the abdomen is made up of elastic type of fibrous tissue. In the midline, it is attached to the linea alba. On each side, it is separated from underlying external oblique muscle by a layer of loose areolar tissue, which disappears superiorly and towards the medial plane. Below, it crosses the inguinal ligament and gets attached to the fascia lata of the thigh, immediately below and parallel to the ligament. To enclose it up to the base of the glans and forms the fascia, Buck's fascia, where it is replaced by the dartos muscle and then continues with the superficial fascia of the Cole's fascia. Clinical importance of Scarpa's fascia. The Scarpa's fascia bears two important clinical relations. It serves as a firm unit for suturing the superficial fascia during closure of the anterior abdomen or perineum after abdominal or pelvic surgery. The attachments of the Scarpa's and Cole's fasciae are such that they prevent the passage of backward into the ischio-rectal fossae and downward into the thighs. The line of fusion of Scarpa's fascia passes over Holden's line, body of pubis, margins of pubic arch, and posterior border of perineal membrane or posterior edge of the urogenital diaphragm. Therefore, and then onto the anterior abdominal wall inferior to the umbilicus in the superficial inguinal space. The presence of urine in this confined space where Scarpa's fascia is attached makes the clinician to suspect due to trauma. The skin of the anterior abdominal wall is almost entirely supplied by the lower 6 thoracic nerves through intercostal and subcostal nerves. One of the most inferior part is supplied by the first lumbar nerve through the iliohypogastric and ilioinguinal nerves. Anterior cutaneous branches. The anterior cutaneous nerves, 7 in number, are derived from the lower 5 intercostal, subcostal, and iliohypogastric nerves. They pierce the anterior wall of the rectus sheath, a short distance away from the medial plane, and divide into the medial and lateral branches to supply the skin. The cutaneous branches from T7 to T10 are arranged in a sequence, with T7 near the xiphoid process and T10 close to the umbilicus. The anterior cutaneous branch of iliohypogastric nerve emerges 2.5 cm above the superficial inguinal ring. The ilioinguinal nerve lacks the lateral cutaneous branch, and its anterior cutaneous branch passes through the superficial inguinal ring and supplies skin on the upper medial aspect of the thigh and skin of lateral cutaneous branches. The lateral cutaneous branches from the lower 2 intercostal nerves emerge through the external intercostal muscle and divide into a large anterior and small posterior branch to supply the skin. The lateral cutaneous branches of subcostal and iliohypogastric nerves appear close to the iliac crest and descend over it to supply the skin in the upper anterior part of the gluteal region. Cutaneous arteries. The anterior cutaneous arteries are the branches of superior and inferior epigastric arteries. They accompany the anterior cutaneous nerves. The 3 superficial inguinal arteries are the 3 superficial branches of the femoral artery: superficial external pudendal, superficial epigastric, and superficial circumflex iliac, and supply the skin of the abdomen below the umbilicus. The superficial external pudendal artery runs medially and passes in front of the spermatic cord to supply the superficial epigastric artery runs superomedially across the inguinal ligament up to the umbilicus. The superficial circumflex iliac artery runs laterally below the inguinal ligament toward the anterior superior iliac spine to supply the skin of inguinal region. Cutaneous superficial veins. They accompany the cutaneous arteries and drain as follows. Below the umbilicus, they run downward and drain into the great saphenous vein in the groin, and thus eventually in the inferior vena cava. Above the umbilicus, they run toward the axilla and drain into the axillary vein, and thus eventually in the superior vena cava. Clinical significance of superficial veins of the anterior abdominal wall. The superficial veins of the anterior abdominal wall anastomose freely with each other and with small veins, para-umbilical veins, which drain the umbilicus. In portal vein obstruction, when the venous drainage through the liver is obstructed, the backflow of blood may occur through the para-umbilical veins towards the umbilicus. As a result, the para-umbilical veins and superficial veins around the umbilicus become grossly distended and tortuous. They radiate out from the umbilicus like spokes of a wheel, producing a clinical sign called Caput medusae. This condition is so called because of its resemblance to the serpents on the head of the Medusa, a mythical lady in Greek mythology. Cutaneous, superficial lymph vessels. The lymph from the skin of the abdominal wall is drained into axillary and superficial inguinal lymph nodes as follows. Above the umbilicus, the lymph vessels run upward to drain into the axillary lymph nodes, anterior or pectoral group. Below the umbilicus, the lymph nodes run downward and laterally to drain into the superficial inguinal lymph nodes. Thus, lymphatics faithfully follow the watershed line at the level of the umbilicus. Clinical significance of cutaneous lymph vessels of anterior abdominal wall. The infections or malignant tumor of the skin in the lower part of the anterior abdominal wall may cause swelling in the groin due to enlargement of superficial inguinal lymph nodes. And similar lesions in the upper part of the abdomen may produce swelling in the axilla due to enlargement of axillary lymph nodes.
Thanks for watching. If you found this helpful, like, share, and subscribe for more simplified medical content. See you in the next one. Keep learning